Good afternoon, and thank you for joining us for our webinar, Emerging CT Imaging Trends, Evolution in Computed Tomography. Before we begin, I would like to go over a few housekeeping items. Today's webinar is being recorded and will be available on our website. To minimize noise and distraction, all attendees' phones have been muted. However, if you have a question or a comment during the presentation, we encourage you to submit it using your Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Mark Casner, RadSite's Accreditation Committee Chair.
Good afternoon, everybody, and I want to add my thanks as well for joining our continuing series of webinars. We have an outstanding faculty today that I think you're going to find we'll learn a lot over the next hour or so. We do encourage you to submit any questions you have. Without any further ado, let me do a brief introduction of our panel. First is Dr. Elliot Siegel. He serves as our Chief Strategy Officer and Chair of our Standards Committee. He oversees standards development activities and product development initiatives. Dr. Siegel is an internationally recognized radiologist who serves as professor and vice chair at the University of Maryland School of Medicine, Department of Diagnostic Radiology, as well as chief of radiology and nuclear medicine for the Veterans Affairs Maryland Healthcare System, both in Baltimore, Maryland. Dr. Siegel has written more than 200 articles and book chapters about PACS, picture archiving and communication systems, and digital imaging, and has edited 6 books on this subject, including Filmless Radiology and Security Issues in the Digital Medical Enterprise. He has presented more than 1,000 times worldwide on a broad range of topics involving the use of computers in medicine. He was named Researcher of the Year, Educator of the Year, and received multiple awards for innovation, including the Smithsonian Award. Dr. Patrick Browning is our Chief Medical Officer, and he oversees and promotes the integrity of all quality-based programs and research initiatives for RadSite. Among other contributions, he serves as a resource to RadSite standards and accreditation committees to optimize patient safety and evidence-based imaging protocols. Dr. Browning attended the University of California, Davis for his undergraduate studies in medieval history and earned a master's degree in the history of medicine from University of California, San Francisco. He then returned to UC Davis, where he completed medical school and his residency in radiology. Continued to pursue his passion for radiology and completed his fellowship with Stanford University Medical Center in body imaging. Dr. Browning led the creation of the Division of Medical Imaging for a portion of Sutter Health. He's co-authored more than a dozen peer-reviewed articles and given numerous lectures and presentations in the United States and Europe. Dr. Browning also remains in active practice as the Northern California Medical Director for Open Imaging. He's also served as a Chief Medical Officer for 2 successful automated detection and artificial intelligence startups, and in a senior leadership position with Magellan Health. And last but not least is Judy Pirtle. Ms. Pirtle is the Senior Director of Clinical Practices and Radiation Safety Officer at Acumen. She's a dedicated and goal-driven radiology professional with a reputation for providing leadership, strategic direction, and regulatory compliance, with 25 years of experience. She is adept at forming close relationships within all levels of an organization in an effort to secure the mission of the company while maintaining the highest level of patient care at the forefront. And so without further ado, please welcome our 3 panelists. We're going to start with our first question, which is, next slide. Okay, CT to screen or not to screen? Why don't we start with Dr. Siegel, please?
You're on mute, Ellie.
Yeah, thanks. Just bringing myself off mute. I was fascinated to hear about your training in medieval history. I think that could come in very often for me running my radiology department. And so I'd love to talk with you about that sometime. But as far as screening, I think screening has been proven to be absolutely critical and essential for population health. And so, you know, the first thing that comes to mind, of course, is lung nodule screening. And we're only at somewhere in the neighborhood of maybe 6 to 8% of the US population that are eligible over the year of 50 with the right smoking history for screening. And I think actually one could be screening even more intelligently other than just smoking and the age, but looking at a variety of other factors that are risk factors, including family history, ethnicity, and other risk factors in addition to smoking for cancer. But it's been documented in the National Lung Screening Trial that there's a reduction of approximately 20% in the incidence in the number in all patient mortality in patients who are screened with CT scanning of the chest rather than screening with conventional radiography. Studies in Europe have had even relatively higher percentages. And so, you know, we talk about issues related to mammography screening, colorectal screening for cancer, you know, screening for prostate cancer. But for me, I think lung cancer screening is really critical. And then there are so many other possibilities. For example, screening for abdominal aortic aneurysm, sort of a one-time screen for patients past a certain age to evaluate for abdominal aortic aneurysms, I think has been demonstrated to have a significant positive impact on reducing the number of patients who die of abdominal aortic aneurysms. People have talked about doing screening for coronary artery calcification, where one has the capability of being able to predict to a pretty confident degree the likelihood that a patient's going to have a myocardial infarction in the next 5 or 6 years or so. And so I think screening done intelligently is really something that we definitely should have as part of our armamentarium. People have looked at whole body screening, and in general, that has been frowned upon. But partly the reason for that was that the doses used were relatively high, and also because there was then an overreaction where patients who got screened ended up having a variety of different diagnostic studies and interventional studies. But I think the wisdom that one might have as time goes on for some of these screening studies to be able to follow up appropriately as we get more and more data. So I'm really excited as time goes on at the prospect of being able to collect and mine data on a variety of different screening studies to better inform how we end up doing it. And I'm particularly excited about AI as a mechanism to be able to, in the background for every single CT study that's done, to essentially turn that into a screening study. If a patient's having a CT scan for whatever reason, we have the capability of being able to use AI to automatically assess coronary artery calcification, abdominal aortic aneurysms, look for lung nodules, look for a variety of other different types of incidental pathologies. And so I think there's screening where we purposefully want to screen a patient for a particular disease, and then there's the screening that happens incidentally as we're doing other types of studies. So if you're asking me the question, Mark, to screen or not to screen, I definitely think the answer is screening in a variety of different ways. I think the biggest challenge in the healthcare system is to figure out what do we do with the data that comes back associated with the studies that are done with screening. And I think in some ways that's a more complex challenge than the screening itself, and making sure that if one is doing a screening program, that one has the appropriate case managers and follow-up personnel, healthcare workers that essentially take those data and then make appropriate choices. I think doing screening without somebody to follow up on the results of those in an appropriate manner is not responsible. And so I think the answer is yes to screen, but one has to have a comprehensive plan for what one does, who one screens, and then what one ends up doing with the results of those. So the answer is a strong yes, but you have to really do it the right way.
Okay, thanks, Elliot. And so we are going to touch on AI, I think, in the next question or two. But before we go there, Patrick, I want to allow you the opportunity to add to what Elliot was talking about, but I want to flip the question a little bit and really touch on something that Elliot talked about, which is are there things we shouldn't be screening for, either because we don't know what to do with the data, or we're exposing the patient to perhaps unnecessary radiation? So I'll give you a few minutes to address that as well.
Sure. I think Elliot did a great job of really explaining the vast majority of how screening should be approached. Absolutely. I think that certain screening doesn't need to be done. I think that the whole body screening that occurred in the early 2000s was an interesting idea in that it was trying to catch cancer or other abnormalities early, but on the other hand, it was the net was too broad, and so too many cases got done, and there was too little really focus on what I think to be the most important part, which is screening appropriate patient populations using an appropriate imaging methodology. I think Kelly made a good point about lung cancer. CT is perfect for lung cancer for a variety of reasons. I think that CT isn't really a good screening modality for prostate cancer at all, but MR is a very good modality. So being able to really apply the appropriate modality to the appropriate potential diagnosis is pretty critical. I think another portion is, as he said, data, being able to make use of that data and being able to really sort of drill down so you're not doing screening on patient populations that don't actually need it. And I think the other thing that's been something of a resistance point in radiology since the sort of the demise of the whole body screening program has been the radiologist. I think very often radiologists already feel like they're overworked. They feel like they don't have enough time to take care of the regular diagnostic cases that come in. Very often when I brought up screening, about which I'm very passionate, the radiologist just kind of groans and goes, oh, I don't have time to do that. And I think when we touch into AI in a couple of slides, we have a solution. If you think about the fact that the majority of screening studies are going to be negative, like unfortunately the majority of colonoscopies are negative, which is never, it's good news, but you know, you kind of say, why did you have to do it? If we can use AI to take care of the patients who are completely normal and sort of sweep them off to the side so radiologists can actually pay attention to the abnormal studies, we might be able to actually screen a much larger number of people. And so that's going to require data, as Elliot said, data analytics, and a lot of work just to validate that what we're doing is the right thing.
Great. Judy, you get the last word on this topic.
Well, I am definitely for screenings, and I think CT screenings are underutilized, actually. They're not very popular. I mean, and how do you address that? Like, who do you educate on that? Do you educate the patients? Do you educate the physicians? CT lung screens, I know in the state of Texas, you can be CT lung screens and not have an actual order for it. You can just walk in and have one done if you get registered for it. But unfortunately, it's not a huge program. And that's a sad injustice to our patient population, right? So I think, again, CT screens just are underutilized for what we want to see out of it, right? Mammography, look at mammography. I mean, everyone knows they have to go get their mammogram, or they have to know when they turn 50, they get their colonoscopy. But what about CT, specifically CT screens? They're not that popular and people don't know about them. So how do we educate the public, or how do we educate the physicians?
Great.
Yeah.
Thanks, Judy.
And I think those are really important points. And the idea of us not screening enough people, that the question is why, and I think it's multifactorial. I think one reason is the perception of radiation dose. People are using low radiation dose for screening. So maybe conventional CT might have been 5, 6, 7 millisieverts or so. One can do low dose screening, and people are frequently at 1 sievert, or maybe slightly less than that. My experience has been that even when we go down to 1/5 of a sievert, and so we go to 0.2 sieverts, that we're still able to screen for lung nodules and adenopathy and other pathology, you know, about 96% as well as when we do full dose, which, you know, can be 25 times that dose that we're using. And so I think we could even significantly lower the amount of radiation that we use for lung cancer screening. And I think the same is true for other types of screening modalities, such as coronary artery calcification. I think one of the challenges we've had in the past with lung cancer screening has been the reporting requirements that one was required to do in addition to, talking with and screening the patient for risk factors, the idea of then reporting to a registry the results of screening. And so I know some of my colleagues and some of the folks who work for me in the department, were essentially just reminding me that it can take significantly longer to do a screening study, CT, than it can to do other types of studies. And yet the reimbursement for radiologists is pretty much comparable. And so I think it would be great to align the amount of time that it takes to perform and interpret these studies with the amount of time that it actually takes from a technologist perspective, radiologist perspective, and then all of the things related to following up on those studies. But I do believe that we could be saving a very significant number of lives that are being lost now by doing screening more generally.
Great. And again, I think what is, touch on Judy's point, actually, all three of you have mentioned it. I think education is critical here. The patients, the referring physicians, quite frankly, even the radiologists for that matter. It's, how do we get people to be more proactive, if you will, with their health? So, all right, we're going to move on to the next question. All right, artificial intelligence, what will utilization be in 5 years? Let's reverse the order this time. Judy, we're going to give you first shot at your thoughts on this.
Wow. I think AI is definitely going to be huge in 5 years. I mean, it's already started, right? And when it talks about, AI, especially like in reports and things like that, and being able to identify, small nodules here that they know they need to follow and stuff like that. But an AI, a power scribe or something, be able to pick that up and actually suggest to a physician that, hey, you need to maybe take a follow-up look at this, and things like that. It's going to be huge. I mean, AI is where the world of, I know radiology is going for sure, and medicine in general. So other than that, I don't know a whole lot of specific things about AI other than I know it's up and coming and we're going to be using it, especially in reporting processes. It's going to be fantastic. I think it's going to catch a lot of things, honestly.
Great. Patrick, let me ask you a more specific question. And I don't know who's on our call today and who's going to be listening, but what's your definition of artificial intelligence and how it can be applied to radiology?
That is a great question. One of the things I think Elliot and I have talked about in the past is that there's a lot of crossover about what people mean by AI. Very often when they talk about AI, they're actually talking about automated detection and then the sensitivity and specificity associated with automated detection, which is obviously very exceptionally important. But AI, as I look at it, is along the lines of what Judy said. It's a machine learning algorithm that allows reports or detection or whatever to actually become more and more accurate to the point that it's actually equally or more accurate than a radiologist possibly. And I personally think this is going to be the next big revolution in imaging. I think that our ability to use AI to take a look at the margins of a pulmonary nodule, or to automatically correct for breathing motion in CT, or to automatically create the lowest dose possible in CT, or automatically center the patient in the CT gantry. I think all of those things are going to involve AI of some sort, because all of those are going to be in a continuous cycle of improvement based on machine learning. And so I think overall it's going to touch on every facet of radiology, CT probably one of the most.
So Elliot, let me put you on the hot seat a little bit here. Does
I love hot seats.
Does AI in 5 years replace the need for radiologists?
Yeah, nowhere close. I mean, this is something that I've been debating for quite a while. And as you probably know, in 2016, we had predictions from a number of different, Ezekiel Emanuel did the ACR keynote talk and the Morton lecture and suggested that, radiologists may only have 4 or 5 years or so before being replaced. And some of the most famous computer scientists that worked on AI algorithms using something called convolutional neural networks, including Professor Hinton from Toronto University and Andrew Ng and others made predictions as dire in 2016 of, we might as well stop training radiologists because we really won't need them anymore, and we'll be able to replace them in 5 years. Well, here we are, 6 years later, and there's almost actually no utilization of AI the way that they had envisioned it. I mean, there are a lot of really amazing algorithms out there, but there's so many challenges to even getting access to the algorithms. I don't want to have each algorithm consumed separately with a separate computer program in a separate location where I've got to go out to a cloud location. It all has to be integrated into my image interpretation workflow, whether that's into my PACS system or advanced visualization system or even my reporting system. And that really does not exist now. And I agree with Judy's point and Patrick's point that, it probably will be to a much greater extent in 5 years from now than it is currently. But even then, I think what we're going to see is functionality much more similar to the functionality that one would see with a grammar checker or a spell checker. Right now, my radiology residents have a lot less experience than I do, but it's not unusual for them to point something out that they ask me about that makes me focus on something that I may not have been focused on initially. And so, it does turn out that extra help really provides some added value. I run an AI conference called CMIMI, where Nina Kotler from Rad Partners essentially, mentioned that they're increasingly utilizing AI, and as time goes on, their radiologists in an increasing number are starting to become dependent on it to the point where, they feel uncomfortable or they feel kind of quote unquote, naked without having that available as a backup. And I think there's going to be in the next 5 years an increasing number of residents, fellows, and radiologists who more routinely use it and would be uncomfortable without it in their practice. And she's shown some significant added value in 2 ways. One is reduced missed rates by radiologists and economic and patient safety issues related to that. And then also using it for quality control, going back and saying, well, if AI, looks back at my last year's worth of studies, then are there studies where maybe the diagnosis could have been made, but wasn't made, and looking at quality assessment also. So I've said this 5 years ago, and I would say it again today, that, in the 5, 10, maybe even 20-year horizon, I don't see radiologists being replaced by AI, but, the aphorism that has been attributed to Kurt Langlotz, that radiologists that use AI will replace radiologists that don't, rather than AI replacing radiologists, I think is the direction that we'll be heading in. But I do believe that as time goes on, there will be subsets of things that AI may interpret as well or better than radiologists, and that will become part of the process. But making findings in an imaging study is only a small part of what we do as radiologists. As radiologists, once the finding is made, interpreting what that means, making recommendations, and then putting that together with other information about the patient, whether they're in images or in the electronic medical record, I think that common sense and judgment is going to be the purview of humans for quite a long time. So I definitely don't think we're going to be replaced in the next 5 years any more than I believe that we would be replaced in the last 5 years.
Right.
And Mark,
Yeah,
to make a quick comment.
Sorry, Patrick, please.
Jumping off what Elliot said, in my experience with 2 different AI companies thus far, I've seen a couple of things. One is that from 2016 to now, one thing that's really radically changed, and maybe Judy can confirm this, is the radiologist's acceptance of AI. When I first started, every radiologist was like, oh my God, this is going to take my job, along the line of what Elliot was saying. And now people are uncomfortable if they can't use it, or they're actually asking for it to be used. And in a very small study I did, well, not small, but I did a study at UCLA, actually looking at the detection rate for pulmonary nodules and radiologist acceptance of AI. I thought it would take multiple studies before the radiologist sort of trusted the AI enough to actually do the automated measurements and so on and so forth. It took 2 studies. And after 2 studies, they stopped jiggling with the cursor. They stopped changing things. They just accepted that the machine was doing an equally good job that they were doing for the measurement and location. And I was surprised that it was that rapid. But I think one thing that Judy will see in Acumen is her radiologists more and more will start asking why they don't have this AI at their facility yet. They want it, they need it. And I think that will be one of the biggest changes over the next 5 years.
What's interesting is some of the largest outpatient radiology practices in the country, and of course, inpatient academic centers are developing their own AI algorithms with their own data and their own images. And one really interesting trend is the FDA is looking at doing something analogous to what it does with drugs, with post-market surveillance, starting to ask the question, how can we, once we've cleared an AI algorithm, whether it's to find intracranial hemorrhage or lung nodules or pulmonary embolism or whatever the purpose is, how can we, once it's actually released in clinical practice, how can we get feedback just as we do from drugs, whether or not it's working or not, and try and figure out to what extent it is or isn't working, and then where is it working and where is it not working? Are there certain geographic areas, patient populations, types of scanners, et cetera, where it works better and worse on? And so they are looking to have a much more granular idea than, the whole question about should it be cleared or not, but is it actually efficacious in practice, which is separate. So it'll be fascinating as we start having systems that monitor performance of these AI systems and hopefully get those back to consumers.
Agreed.
Judy, anything more to add on the topic?
About radiologist acceptance, I mean, to me, it seems like that you would want something that helps you make better reporting, right? I mean, your job as a radiologist is to report accurately, as you possibly can for patient diagnosis. So, I mean, with AI, I just think I do not feel either that it's going to replace a radiologist's job, because at the end of the day, it's just, you need both. And why not use AI where it's to your advantage and makes better diagnoses?
One interesting point is for mammography, we've had CAD for quite a while. And in general, the practice across the country has been not to save the CAD marking, so that the radiologist has the CAD recommendation in making her or his assessment about whether or not there's malignancy or what the findings are. But then once the case is interpreted, those CAD markings essentially disappear and they're not stored. And I have always believed that it's important to do that. And I've actually had a disagreement with Lenny Berlin, who I respect tremendously, where his recommendation has been not to store the CAD markings, quote unquote, for medical legal reasons. I believe that they should be stored for patient care reasons and medical legal reasons. But regardless of the debate about mammography and CAD markings, one question is, moving forward, how do we store AI recommendations or interpretations? If Patrick is disagreeing with AI after he's considered what AI is suggesting as far as pulmonary embolism or intracranial hemorrhage, and then he essentially makes his interpretation, should he include the fact that he's disagreeing with AI? Should that marking or disagreement essentially, be persistent, so that at least clinician knows that AI thought that it was positive, but Dr. Browning, based on all of his expertise and experience and reviewing the CAD markings, decides that he wants to override that, which clearly in the vast majority of cases, he would be correct. And so it's another interesting question about to what extent should AI's opinion or recommendation be presented to clinicians, patients, and be stored as a permanent part of the electronic medical record.
At the end of the day, my tagline for AI is that it's one of the few inventions in radiology that's going to allow radiologists to do more studies more rapidly, more accurately. Most of the time, you've got a trade-off somewhere. This is one of the times, and to your point, Elliot, you're right. There will always be disagreements among radiologists and AI, but at the end of the day, it'll be revolutionary, I think.
Agreed.
I'd like to stay on this for a little bit longer. So to me, again, it comes, and we've been talking about different cultural differences and stuff. What do you think, anymore you're driving down the road and you see somebody's car who's driving automatically, right? And it's a little off-putting. I just think technology is it's almost overwhelming us these days. What do you think the acceptance for the patient? So they come and get the study, and they come to see their radiologist or whatever. They get a report from their referring physician, and almost seems robotic to me. What do you think the acceptance rate is 5 years from now in terms of the patient's ability to say, okay, a machine just told me I have X, Y, or Z, and I'll open that up to the panel, whoever wants to jump in first.
I think it'll be like laboratory values. Patients don't question laboratory values anymore. I mean, 50 years ago, you used to do cell counts by hand in a microscope. And so I think patients will be very accepting as long as their clinicians and their radiologists are accepting of it. If there are naysayers, and that'll always cast, seeds of doubt everywhere. But for the most part, the more we work with it, the more we find it's effective, the more we find it's making us more accurate. I think the more patients will say, well, Dr. Siegel and Judy love this, and so I'm going to go ahead and just take its recommendation based on the fact that they love it and it works really well. I think patients will go along.
Yeah, I agree. I mean, in the cars that you're talking about that are self-driving, you still have the human that's sitting there in front of the steering wheel. And I know, having a self-driving car myself, it's the human plus the car together really provide, in my opinion, a safer combination. So I think that patients are going to be positive about AI, but it really is a matter of education for patients. And I think the idea in 5 or 10 years is you may have practices that are actually marketing the idea that their radiologists are looking at the studies and that they're enhanced or augmented by AI also. And so it'll be really interesting, the concept of accreditation. We talk about accreditation of CT scanners and MR and PET scanners, et cetera. The possibility of having AI applications that are in some way beyond just FDA cleared, but potentially accredited as well. And so I do believe that there are lots of steps that are required for not only patients, but our referring clinicians and radiologists to feel comfortable with the technology. But I think nowadays people do feel comfortable with having a computer help or augment their judgment. And I think, spell checkers, grammar checkers, and a variety of other computer systems that are checking and back checking on humans are becoming more universally accepted.
Well, and anymore, we all get our healthcare from the internet anyway, so
yeah,
probably we're all going to be obsolete here. All right, let's go ahead and move on to the next question, because I want to make sure we cover a little more ground. Okay, photon counting CT. Patrick, why don't you take the lead on this one?
I think, it's been a number of years since there's been any sort of a revolutionary change in the mechanics of CT. Everybody talks about how, fast they are, and they're incredibly fast now. You can do a whole heart in 15 seconds. I think that's been the culmination of a lot of small changes over the course of my career, one of which has certainly been computing, in addition to more detectors and faster rotation times and so on and so forth. But one of the things that really hasn't changed much has been the detectors themselves. They've stayed pretty static. The way they work has been pretty much the same for, 40 years now or something like that. And I think photon counting CT is going to be a pretty big revolution. It really allows you to get a much greater degree of detail without a much greater degree of radiation at all. I'll let Dr. Siegel, who is an electrical engineer, explain the mechanics if he chooses to. But overall, I think this will be the next big thing in CT. I'm not certain that it will be a demand thing as much as I think that, and Judy can probably speak to this, but as organizations replace equipment, I think they'll choose to replace it with photon counting equipment rather than standard CT equipment going forward. I don't think everybody's going to rip out their brand new, 365 detector scanner and plunk in a photon counting CT, but over the next few years, I think on our replacement strategy, this will be the next big thing.
So Judy, let's go to that. Obviously, one of the things that we deal with in imaging in general is the equipment's very expensive. Some have good lifetimes, some not so much. I mean, the technology, again, can be overwhelming. As you think about it from an administrative perspective with your company, new technology, do you start to throw out all of your old CTs and bring in some new ones?
Well,
Maybe share your thoughts.
We would absolutely love to do that, right? Just, as long as you're providing us with all the money to buy the new equipment. So, I mean, but it's like, Dr. Brown said, it's not changed in so many years. I mean, honestly, other than faster scans, and we do have, better radiation doses now than we had 40 years ago, obviously, but definitely, newer technology is the way anyone wants to go, right? You want the best for your patients. I mean, at the end of the day, it's about patient care and providing them with the best patient care, the best machines that you can get for the best diagnosis, right? So photon counting is great. And I kind of feel like it's kind of a slow pickup. It's not been something that's been so widely used or talked about as much, where like advances in MR are huge and different as opposed to CT. It's basically been the same, except faster machines. So from an outpatient imaging aspect, yes, we would love to have the newest and best for everything. Unfortunately, the lifespan of a CT machine is pretty long, and for what you pay for it. So versus the need. And I think that's what you have to really take into account is what is your need in the area that you work in, or at the center, say a center in Dallas, as opposed to a center in, Wichita, Kansas or something. What does the patient need? I think that would be the driving point of whether you would switch and upgrade your machine versus keeping your old machine.
And Judy, the lifespan of CT has really dramatically increased over the past several decades, right? It used to be at RSNA every 3 years you'd have to buy a new CT scanner. Now I audit places, the CT scanner is 17 years old and it's working great. I mean,
yes, you only have to replace the tube because it's you only have to replace parts, right? Because it's the same concept. I mean, not a lot changes with it. So what wears out the quickest is the tube. So you can keep replacing the tube and the machine keeps going. So.
So Elliot, ignoring the economics for a moment, any advantage to moving to photon counting?
Sure. Well, lots of advantages. So just one point I wanted to make is the fact that when MR, came out and was used for broader applications, people were sort of saying, well, nothing exciting or interesting is happening with CT. It's kind of a static technology, medieval history, as might call it. But there have been some really cool advances in CT. I mean, multispectral CT
Correct.
been a really interesting possibility for being able to better distinguish between intravenous contrast and calcium, and to be able to better characterize a variety of different changes in soft tissues. And it hasn't caught on as much as a lot of the really fascinating possibilities that there are for it. And there have been lots of academic talks on it, but it really has not been as broadly implemented as one might imagine, even though it's a relative free lunch where you can do it without a significant amount of additional radiation. Iterative reconstruction was taken from nuclear medicine. Nuclear medicine needed iterative reconstruction rather than filtered backplane because of the fact that we're so relatively photon starved with nuclear medicine. And then, the idea of being able to count individual scintillation events in nuclear medicine is so important because there's so much radiation associated with injecting a patient that you want to keep the dose as minimal as possible to minimize exposures, because patients are living with that dose until the dose decays or it's eliminated from the body. And so, being able to count individual photons in nuclear medicine is something that I think is moving to CT with the potential, just as is true in nuclear medicine, to better characterize particular energies that you want to use and to be able to better characterize, individual photon events so that you can significantly reduce the amount of radiation. And I think that there's tremendous potential to be able to get much better images with a much, more sensitive detection efficiency. And those have implications for being able to do pediatric patients where, dose really is important, potential to be able to provide significantly better images than one might have otherwise. So I think there's some really cool developments in CT going along with reducing dose and being able to now have multi-energy capability to be able to better characterize tissues. So CT's come a really long way over the past few years. I think the challenge is that, there aren't that many people that are buying photon counting CT, and so it still remains expensive and still, remains more in the realm of tools in academic centers. But I think just as we've seen over the last several years, a lot of those technologies trickle down, become less expensive as more people are interested. And it really does provide the potential for better patient care by reducing dose and providing more precise energy specific images that allow you to do a lot of things that improve our ability to make diagnosis.
Great. Okay, let's move on to the next one, because I think this topic is going to probably take us right to the top of the hour. But and I'm going to add a second question as part of this. So how to most effectively utilize the radiologist's time and work output. And the panel had an earlier discussion before we even got on the webinar in terms of the appropriateness of studies that are ordered, and how does the radiologist interact with the referring physician in terms of doing what's best for the patient and not necessarily just doing what has been ordered. So let's start with Elliot for that one.
Yeah, so I think this gets to all sorts of different issues. It gets to appropriateness criteria for, what examinations actually should be performed in the first place. It gets to the question of what is the correct examination. I mean, nowadays with so many different options between ultrasound and even contrast enhanced ultrasound and a variety of advances in ultrasound plus MR plus CT, as we talked about, and other modalities that are emerging, I think it really can take a radiologist to actually make the determination of what is the proper study to do. And then as far as radiologist time, we've done a variety of different studies looking at how much of a radiologist time, if a study takes X amount of time to interpret, is really spent with the radiologist looking at the images and making a determination of what she or he thinks about the diagnosis and findings, and how much of it is waiting for images to come up, waiting for them to be arranged, waiting for, reporting systems to come up, and, clicking a variety of different things that we have to. And so I think that there's still in 2022 tremendous potential to be able to rethink how we end up working in our workout output. We talked about AI applications, and there are a variety of really clever things that are coming out. Like, sometimes radiologists may spend half their time creating an impression, and the first half creating the body of a report. But what if you could create the impression automatically if you knew what the body of the report was? What if you had the capability to be able to have information synthesized from prior studies or the electronic medical record, so that you would have that as you made a diagnosis? We talked about AI and the potential for AI to make radiologists faster, and that's been documented recently in studies that have been done with the addition of AI for a variety of different things, including detection of pulmonary embolisms. So I think that there are a number of different ways, and I also have done a lot of work in reading and research in the radiologist cockpit, the idea that we radiologists, are working in environments that are not particularly ergonomically friendly. We have noise distractions, we have, suboptimal lighting. And I think those are all things that can also, make us use our time more effectively. And then there are a whole bunch of communication systems that are coming out that allow me to close the communication loop. I think one of the biggest challenges in radiology right now is we radiologists look at images, make recommendations for follow-up studies, make recommendations of findings, and in general, they're often not actually followed up in a proper way. And so being able to record those recommendations and create follow-up mechanisms to be able to actually do those creates much more effective communication and closure of the recommendation loop for patients also. So I think there's a huge amount of opportunity that we have to more effectively utilize our time and work output. And I think radiologists, believe and are accurate that, they're working at full capacity, and they are, but it's the constraints of the system that they're under. And I think we have the capability of actually reducing stress and burnout and becoming more productive if we just re-engineer and rethink the way we practice.
Okay. Judy, you had volunteered earlier some of the approaches that you have taken in terms of being able to address the whole accuracy and appropriateness of ordering. Maybe you can share your thoughts on that.
Absolutely. So, to make a radiologist time more effective, you have to be effective at all levels. The technologist has to be effective. I mean, scheduling can catch some things as much as their, medical background can allow. However, for me, and working in CT scan for 20 something years, it's about catching these things before the patient walks through the door, right? It starts way before it ever gets to the radiologist. So to me, if you want the radiologist time to be effective, it has to be effective at all levels. So either that's at scheduling, technologist. I know that we require our technologists to check orders at a minimum the day before. We try to do it, few days out or a week out, as far out as we possibly can. And then from there, make sure that the diagnosis matches the order. We preach that. It's in our policy. We make sure that that we are following the rules because we want to do what's best for the patient, right? One of the things that I know a hospital does here is they have techs that actually sit in scheduling, and they vet those orders as they come in, which is an amazing idea because a tech by background is going to know appropriateness versus, hey, this is not supposed to be a CT scan, this should be an MR. And they're going to catch that before it even goes in the system. And they're going to pick up the phone and call the doctor and say, hey, this, according to our, verbiage here, it should be this versus this, and try to catch it on the front end. So I think there's a lot you can do to, effectively utilize a radiologist's time. And it's being effective at all levels.
Great. So Patrick, a couple things. One, we've spent a fair amount of time talking about screening and the potential impact on the radiologist's time and whether they like it or they don't like it. And I'm reminded of your medieval history as well, looking at the light box behind you. But you look at CT today, right? So it used to be not so long ago, you get one slice CT. Right now, you've got a gazillion slices, and so there's almost too much data for a radiologist to sort through. So help me or help our audience understand, how do those things weigh in on all of the things that we've been talking about in terms of the effective utilization of your time?
That is a great question. I recall specifically that a number of years ago, one of the radiologists I was working with, we had just gotten a new multi-slice CT, and so I said we should start automatically doing coronal and sagittal reformations, and he's like, I don't want to look at more images. No, I don't want to do that. So radiologists all have a particular level of data overload. I think that, as Elliot and Judy both said, it's the way that the data is being presented to us that is creating the biggest issue. If we synthetically take all the things we just talked about, automatic importation of numeric data into the radiology report, automatic generation of an impression based on the body of the report, using voice recognition and field fields and pick lists and things like that, and using templates, because templates have been shown to be much more effective and much more actually preferred by the referring clinician. In addition to AI doing automated detection, automated measurement, automated analysis of the images and the studies, all of those things I think will come together to be able to allow the radiologists to not feel like they're drowning in data any longer, because they'll revert back to being diagnosticians. They'll be looking at potential abnormalities, just as Elliot does when he's teaching. The resident points out maybe 50 things on a CT. Elliot sorts through them and says, okay, only 5 of them are actually accurate. But it's sort of been preloaded by the resident, who's incredibly sensitive to everything that might be wrong, and so points out everything that could be wrong to Elliot. But they're pretty good at, if it's normal, it's normal, so they ignore it and just point it out to Elliot. I think doing those things, in addition to potentially, I mean, this idea was given to me by a Russian head of a very large radiology organization in Russia. His goal with AI was to develop an AI that was so sensitive that with 99.99% accuracy, if it called something normal, they were not going to even have radiologists look at it. And he expected they'd be able to get rid of 30 to 40% of their volume that way. So there are a number of strategies. I think using all of them is going to, at the end of the day, allow radiologists to work much more effectively and efficiently and more accurately, as I said as well. But it'll take everything, maybe done in small steps, but I think it'll take everything sort of becoming synthetic for the radiologist and getting rid of what right now is a lot of groundwork in preparing a report.
Yeah, I agree with Patrick. And I think one thing to underscore is that these are not at this point nice to haves. These are must haves. We're in the process of, we're in the midst of a pretty dire shortage of radiologists, a pretty dire shortage of technologists. And so I think we really absolutely are mandated at this point to be able to rethink both radiologists' time and work output and that of technologists and other people who work in healthcare in general. And so I think that, part of the reason that AI is going to become more popular is that it's going to be absolutely essential for us to have that in order to maintain and be able to respond to the volume of studies that are being requested and being performed.
Yeah, great point. Great point. All right, we're fast approaching the top of the hour. So I want to, if you'll skip to the next slide, Julie. Actually, let's go ahead and skip to the last slide. Yeah, so Judy, let's start with you. As you think about, again, where you are with your practice and how your company interacts with this, where do you see CT imaging in 1 year, 5 years, 10 years? I mean, give us your own sense of crystal ball as to where you think things are going. We've obviously talked about artificial intelligence. We've talked about a lot of new technology, perhaps photon CT, but give us your thoughts as to where you think this is going.
Well, I mean, I hope that, I hope that, CT in 5 years and 10 years from now, we all have the best of machines. When she flipped from that last slide, it was like, what's the minimal CT? Is it 16 slice? I mean, we still have 6 slices and 4 slices out there. I mean, and we have up to 512 slices. So, hopefully, and obviously the higher the slice, the better the better the scan or the faster the scan time and things like that. So, I would think that the hope is that in 10 years that the 16 slices are obsolete and, you have a minimum 128 slice. You want to reduce dose, right, to patients and make it faster and things like that. So, in my mind, CT in 10 years from now should look way different than it does now, especially with photon energy coming out and those type of things. So in spectral CT, you don't really hear a lot about spectral CT, not in, just regular outpatient imaging. So, I would hope that those are advances in CAT scan and therefore they should be utilized more. Unfortunately, they're just not a whole lot right now. And like Dr. Siegel said, we have a lack of radiologists and a lack of technologists. So we need people to drive this, right?
So Patrick, as you think about it, and you've seen the progression of technology over the years, is CT around in 10 years? Is there some new technology or something else that's out there, or is there always going to be a place for CT in some fashion?
I personally think that's a great question. I personally think that in the broadest spectrum, CT will always be around. I think the basic modalities as they are now, including nuclear medicine, MRI, CT, ultrasound, regular radiology, I think they will be around. They will be different. I think they'll be administered differently. They'll be performed differently. They'll be interpreted differently. They'll be, I hope, much more efficient in a lot of ways. I hope the radiation dose will continue to decrease as it should. And who knows, AI being what it is, it may be at some point, there will be one CT technologist running 15 facilities just to sort of oversee the QA while physician or radiology extenders or whatever position the patient on the gantry, and then AI takes care of everything after that. I mean, the entire role of the technologist may be automated in 10 years, except for very rare circumstances. So I think it will be around. I think it may be moderately different than it is today, for sure, just as the studies we do today are significantly different than the studies we did 25 years ago, as Elliot pointed out.
You know, Elliot, you've been in the forefront of a lot of the technology changes that have occurred over the years. And so I'm going to give you the final word, if you will, in terms of where you see it going. And we've covered a lot of ground this afternoon. And as you kind of bring all of those pieces together, you know, what's your crystal ball telling us?
Yeah, well, so I agree with Judy and Patrick on a number of different points. I think that we're going to increasingly be making the transition where the baseline CT scanner is going to be multi-slice and multispectral, you know, as we go to 5 to 10 years. I think Patrick's making a really important point that, you know, already even this year, forgetting 1 year from now, we're seeing more and more remote CT applications, and we're, you know, figuring out to what extent one essentially can have one tech operating multiple systems. How does that stay within some of the requirements for state laws with regard to who can operate the CT scanner? I think the same way we're seeing automation in our shopping malls and restaurants and other places, we're going to be seeing it in CT also. If I take the question, where will CT be imaging, you know, where will CT imaging be? I think we're going to see more of an emphasis on imaging outside of the hospital and maybe even outside of the imaging center. And, you know, we'll be looking at portable MRI scanners and CT scanners in outpatient nursing home settings and in essentially extended living and rehab settings. And so I think we'll be seeing more ubiquitous application of CT. I think CT may well eliminate or at least supplant a lot of what we're doing with X-ray imaging in the next 5 to 10 years or so. Being able to image using a CT scanner at the dose of X-ray, I think is a really compelling prospect. And we're seeing more. We're seeing different types of CT scanners. Cone beam CT has been supplementing conventional CT, you know, at low doses and acquiring really interesting images for subspecialty types of applications that are supplementing CT. So I'm super optimistic that in, you know, the next 5 or 10 years, we'll be seeing major advances. And one of the major advances that we're seeing, combining our discussion on AI and CT, is a major reduction by AI in the amount of noise associated with CT images. And so AI will be increasingly used to help form the images in CT so that we'll have, you know, for the same type of equipment, much higher quality images, higher resolution images, and less noisy images. So I am on the same page as Patrick and Judy as far as being really optimistic that CT in the next year, 5 years, and 10 years is going to advance significantly. I think we'll be doing more screening studies. I think we'll be doing them in more places. I think the technology will progress significantly, and I'm really excited about the future. And I think it's really important to continue to have webinars such as this one to continue to educate our radiologists and technologists on what's coming, what the options are, and what some of the advantages and trade-offs are. So really appreciate the opportunity for all of us to participate in the webinar.
And I want to personally thank our panelists today. We've covered an awful lot of ground and learned a great deal. So we probably could have spent a full day talking about all the various topics that we covered today. Hopefully it was informative for our audience as well. And with that, Julie, I will turn it back over to you.
Thank you all. I do have a comment that someone just posted. Such great, interesting information. Thank you all. Great job. And just as a closing reminder, today's webinar has been recorded and we will be posting it onto our website, and so it will be available shortly. If you enjoyed this presentation, be sure to check out the webinar page on our website for past webinar recordings. If you missed one or would like to hear one again, this is where to go to download the recording. As Dr. Siegel said, he brought up cone beam CT. There will be a whole series on cone beam CT. So if you're interested, the first one is next week. So check that out on our website as well. And as I said, we hope you will continue to join us for our webinars. Thank you and have a great day. Bye.
Thanks, everyone.
Thank you, everyone.
Yeah.
Thank you, Julie.
Great to see you all.